brain injury. So traumatic brain injury. It's on chapter 57, acute intracranial problems, page 1367. So traumatic brain injury is a skull or brain injury serious enough to cause damage to the normal functioning. All right, let's talk about the types before we get into all of this. So there's primary and secondary. There's coup and contra coup. That's a separate thing. Let's talk about primary and secondary first. So primary could be open or closed. It could be comminuted, linear, depressed, or compound. So these are the different types. So open or closed skull fracture. So the different types: comminute, linear, depressed, compound. The secondary, we're going to be thinking about infection, hypoxia, fluid, electrolyte balances. So that's what we're thinking about overall. Now, what we're saying coup and contra coup, it means coup and contra coup. Let me look that up real quick, but it's more severe, often causes a severe injury. So I'm going to go look that up real quick. Coup. It's always good to get images. So it's that motion going back and forth. It's like hyperextension and hyperflexion. So the coup is forward and the contra coup is backwards, to get you an idea of what's going on here. Okay, so then we got focal and diffuse. So our focal has to do with our lacerations, our cranial nerve damage, very focused contusions. Our diffuse is more like a concussion, a diffuse axonal injury. So that makes sense. So things are more diffuse, focal is a specific area. All right, so then we're going to talk about the quick clinical manifestations that we would see. So this is also where it's important to understand the different parts of the brain and stuff like that. So it kind of differentiates between the different types. So there's different hematoma types. That's something I'm going to add to my list of things that I should look up. Hematoma types. Location determines the manifestations. That's really important to understand. All right, so when we talk about scalp lacerations, we may see a hemorrhage because laceration. There's intracerebral, depends on the space it's occupying. So ipsilateral dilated pupils, there could be contralateral hemiplegia, unconsciousness. It really just depends where the space is occupying. So skull fractures, as we discussed earlier, it could be comminuted, which is like a bunch of little pieces, linear, or depressed, bruising the dura. And skull fracture, you can also see hematoma. All right, so the basilar fractures, which is our linear fractures, specifically for basilar fractures, is specific. What we're going to be looking for is very specific signs and symptoms, like super, super specific, like things you need to remember, like super important. Okay, so the basilar fractures, you'll be looking for rhinorrhea or otorrhea, CSF, basically coming out of your nose or coming out of your ears. Those are big signs. You may see raccoon eyes, like periorbital edema around here. That's where you see a raccoon eyes. The battle sign is the post-auricle ecchymosis behind the ear. Okay, so now we talked about all that. So now we can talk about the focal ones. The focal is associated with a closed head injury. So like contusion, you may be rebleeding. So contusions, you may be rebleeding. Seizure is the first 7 days of really high risk. So you also want to think of coup and contra coup also. Let's talk about concussions, which are diffuse. There's a mild, and there's moderate, and there's post-concussion. So the mild has to do with no loss of consciousness. There's a brief period of disorientation and confusion. That's a mild. They may or may not have retrograde amnesia, meaning they can't remember what happened during that time. A moderate is a temporary loss of consciousness, usually less than 5 minutes, and no longer than 6 hours. Retrograde amnesia or post-traumatic amnesia is always present. And other signs and symptoms would be, let me open this up real quick and tell you: headache, a dizziness, nausea and vomiting, visual disturbances, difficulty concentrating, poor behavior, memory disorders, irritability, anxiety, and insomnia. Now, post-concussion, you want to teach those caregivers when patients discharge home 2 weeks to 2 months. that this can happen. So 2 weeks to 2 months, they can be at risk for this extra post-concussion stuff. So remember that. Diffuse axonal injury is basically with these concussion. That's basically a widespread axonal damage. It could be mild, moderate, and severe, just like concussions. This can lead to decortication. You want to look for decerebration. That's from the ICP. Remember that. Core, close to the core, it's flexed, and decerebrate is more extension. So increased ICP, decreased LOC, global cerebral edema. You may see a persistent vegetative state from this. All right, so now look at the assessments that we need to do as nurses is you want to assess for a lot of things, actually. So the basics of nursing subjective, objective signs and symptoms, obviously medication, you need to know if they're on anticoagulants for traumatic brain injury. Respiratory, you want to look at the rhinorrhea, your gag reflex, your inability to maintain a patent airway, impending herniation, altered irregular respirations, and cardiovascular impending herniation such as Cushing triad, GI vomiting, projectile vomiting, bowel incontinence, urinary bowel incontinence, reproductive uninhibited sexual expression. Your neurologic would be altered LOC, seizure activity, active pupil dysfunction, cranial nerve deficit. And your motor weakness, you're looking for the palmar drift, the paralysis, the spasticity, decorticate, decerebrate, posturing, muscle rigidity, flaccicity, and ataxia. All right, so when we say altered and absent gag reflex, this would be glossopharyngeal cranial nerve 9. Just remember that. So cranial nerve 9, we want to think about our altered or absent gag reflex. Projectile vomiting, LOC being altered, confusion, headache, seizures, pupillary abnormalities, sudden onset of neurologic deficits, hearing, vision, sensory motor. You may see a change in vital signs like respiratory. Cushing triad. So what's that? Cushing triads is hypertension, a widening pulse pressure. I'm just putting a list of things that I want to put really research more into. So Cushing triad, so widening. I want to put more research into that. So they would have bradycardia with irregular respirations. And there may be damage to the pituitary, like it caused DI or SIADH. So what are the diagnostics that we're going to do for this patient? So to get a wrap up of the diagnostics we would do for this patient would be a dextrosticks or test tape strip, which would be assessing for glucose in the CSF. You want to test for CSF fluid with a halo sign. So if blood's present, we'll concentrate in the middle, and a halo yellowish ring encircles the blood, coalesce in the center. If CSF is present. CT scan is the fastest. You want to get ICP. A glaucoma scale below 8 is a severe level of consciousness, so we can go over those scores real quickly. So CSF, 13 to 15 is considered mild, 9 to 12 is moderate, and 9 severe. So you're testing for the best eye opening, the verbal response, the motor response. That's what you're looking for. You're also going to do the MRI, the PET, evoked potential studies, cervical spine x-ray, stuff like that. So our complications, to give you a quick wrap up, is hematomas, contusions, skull fractures, and lacerations. So our lacerations, we're worried about infection because it's open. We're worried about hemorrhage, intracerebral hemorrhages, subarachnoid hemorrhages, intervertebral hemorrhages in general. Skull fracture, we're also worried about infection, hematomas, tissue damage. For contusion, focal, there's a risk for rebleeding, especially 7 days after. You want to ask about anticoagulant therapy because you don't want them to bleed anymore. It may be blossomed on the CT scan, meaning multiple places, and seizure. So also for hematomas, they would be given an epidural. So let's go ahead and look at that. So a collection of blood between the skull and the dura mater. Arterial rapid, venous slow, meningeal artery tearing, common causes. Oh, the epidural area. So collection of blood between the skull and the dura mater. Arterial rapid. Okay, so arterial is rapid. Venous is slow. Meningeal artery tearing, common causes. Brief loss of consciousness. Lucid period, a decrease in LOC. Emergency, brief loss of consciousness, rapid deterioration of neurologic symptom, needs surgery and evacuate hematoma. So in the epidural area, it's very serious. The intracerebral is hemorrhage in the brain tissue. It's mass lesion. There's also subdural between the dura and the arachnoid matter. Majority is venous for this one. So there's an acute, a subacute, and a chronic. So acute is happening in 24 to 48 hours, so like 1 to 2 days. Symptoms related to ICP, it's increased. There's decreased LOC. There's a headache, ipsilateral pupil dilation, fixed and severe. So for the subacute, it's 2 to 14 days, so like 1 to 2 weeks of injury may appear and enlarged over time. While the chronic is weeks or months. So hematoma is really a pocket of blood. More common in older adults and present of focal symptoms, risk for misdiagnosis. So this can happen over time. So it's usually really risk for older adults. So epidural is usually associated with, whenever it's associated with arterial, it's more rapid and so it's more risk. So you're going to see that brief, the loss of consciousness, the lucid period, the decreased LOC. And you need quick evacuation of that. All right, so that's the complications. So now let's talk quickly about the interventions, what we're going to do for these patients, how we're going to take care of these patients. So how are we going to take care of these patients? Our acute interventions, well, what are we going to do? To avoid it, we should give patients seatbelts and helmets, and it should be crossed over because, you don't want to hit your head forward and backwards. It's good to have a seatbelt that really protects you. Okay, we're going to talk about acute real quick. So acute, you're worried about hyperthermia, so you want to prevent shivering. Eye problems, eye drops, compress, maybe an iPad, compress, and a patch. For CSF leak, you may want to give no NG tube and no nasotracheal suctioning. You want to tell them to not sneeze their nose or blowing their nose, and head of the bed needs to be elevated. Loose collection pad they may need. Okay. So that's the acute measures. So for concussion or contusions, management of ICP and observation, you want to advise to avoid activities, quiet rest periods, and teach post-concussion syndrome can be 2 weeks to 2 months, as I described earlier. That's really when it comes down to the concussions, teaching to look out for that. And quiet rest periods and the management of ICP. So we'll talk about acute rehabilitation after that. So initially assume the neck injury also, so until rule out of it. And so you want to mobilize that first. For a skull fracture, you want a surgery. If it's a depressed one, conservative surgery if depressed, conservative treatment for others. Also for surgery, invasive procedures like subdural, epidural, and hematomas. A subdural and an epidural, you want to do surgical evacuation, craniotomy, burrs hole, craniectomy if extreme swelling. So, yeah, this may require surgery. Administration of antibiotics with positive CSF fluid test. It's a risk for infection. Insert NG tube with a basilar fracture. I got to do more research on this NG tube thing. NG tube. Okay. All right, so emergency treatment would be, you want to make sure they have a patent airway, stabilize the cervical spine, oxygen, IV access, intubate if they have a glaucoma scale less than 8, control external bleeding, and remove patient's clothing, especially if they are at risk for seizures. Ongoing monitoring is maintain the warmth, warm blankets, IV fluids need to be warm humidified O2, warm heating lamps. You want to avoid coldness. Okay, so monitor vital signs, LOC, cardiac rhythm, O2 stats, GCS scale, pupil reactivity, rhinorrhea, autoria, scalps, wounds, administer fluids cautiously, increase in ICP. Because the pressures increase in ICP. Gag reflex absent, intubation. For pharmacology, you're going to give them antiemetics if there's increased ICP, and analgesics, which maintains the temperature. Also, for acute rehabilitation, you want to teach to no smoke or drive or alcohol, seizure management, educate the family for progressive recovery, like mental and emotional difficulties. So you want, for acute rehabilitation, you may want to tell them about like your motor and sensory, bladder management, preventing DVTs, hydrocephalus, nutrition, dysphagia, communication, because all of that is related. So really that's the overall of everything. And it's really knowing about having to assess for that hematoma of like where it's located and if it requires immediate surgery and being prepared for that and expecting it. So that's everything for traumatic brain injury. Happy studying.